Great to have everybody back at Einstein's Eyes. Your co-host Carl Rosen, ocular plastics, neuro-ophthalmology with Jack Cannerdale in Pittsburgh, now in Anchorage, Alaska for the past 30 years, trained at Albert Einstein College of Medicine with Ron Bird as chair, with my friend and co-host and former co-resident, Jon Ditkoff.
Hi, yeah, I'm a general ophthalmologist. My name is Jon Ditkoff, and I specialize in cornea. I've been in northern New Jersey for over 30 years. As Carl mentioned, we both trained at Albert Einstein Montefiore Medical Center, hence Einstein's Eyes is the name of our YouTube channel. So we're glad you're here, and we have an interesting topic for you today. I really wanted to talk about something else, but Carl talked me out of it.
Right.
So we'll do that another time.
Right. It goes back and forth like that. But we're going to dive into multiple sclerosis, MS. Who gets it? What does it do to the visual system, the treatment landscapes, and with a spotlight on the first oral disease-modifying therapy known as Gilenya or Fingolimod. The reason that this drug, Gilenya, is interesting is because it can cause macular edema, or there's a risk. It's a low risk, but every eye care provider should know about it.
And every neurologist, I mean, I see some patients that are on Gilenya and they come in and they kind of casually mention, I said, did your doctor tell you that you should be seeing an eye doctor at least once a year? Well, and most of them say no. So I think any doctors out there watching this, you have to make sure your patients on Gilenya are seeing an eye doctor.
MS is blurred vision, double vision, eye pain. Sometimes the eye pain and the blurred vision is the first clues that you may have MS. We can see here the vision problems associated with MS. You can have something called optic neuritis as the presenting sign. Optic neuritis tends to occur in younger women around the age of 30, but it may be the first manifestation in roughly 20 to 25% of people, and in 50% of people over a 15-year period. And this was identified in the optic nerve treatment trial back in 88 to 91. 50% of people can go on and develop MS. There are other issues with MS called nystagmus, where the eyes jiggle. You can have double vision, known as diplopia, where you see two images. And there's another interesting thing that happens when you get overheated, Uthoff phenomenon or syndrome, that causes your vision to get blurred as your body temperature rises. Give you a snapshot of the demographics. MS affects about 1 million people in the United States, roughly 3 women for every man, with the peak onset, as I mentioned, between 20 and 40. The prevalence climbs the further you live from the equator. So think latitude gradient. So about 11 to 16 cases per 100,000 per degree. So in Anchorage, and a shout out to Anchorage, Alaska, we see a lot more optic neuritis than you would in Miami, Florida. And that stat really does check out. So as I was mentioning, optic neuritis is painful vision loss with a pupil problem. Your pupil doesn't react to light as well. And that can be the first initial manifestation. There's something called, and this is a mouthful, an INO, which stands for internuclear ophthalmoplegia. And that occurs as a result of the immune system attacking your myelin, or the insulation around some of the nerves, particularly in this thing called the medial longitudinal fasciculus in the brainstem. You can get an eye that one eye doesn't move and the other eye has something called an abducting nystagmus. So when you look out to your left or to the outside, the eye will beat or jiggle. And one other thing that's come to light, this was identified really in academic centers with an instrument called the OCT, the optical coherence tomography instrument, which lots of us have, is you get ganglion cell and nerve fiber layer thinning. And this is emerging as a biomarker. Jon, you want to touch anything on that?
I guess my clinical experience. So I've seen people come in my office, 28-year-old woman with mild decreased vision. She might have a field cut or just is not seeing well. Oftentimes they'll notice that things look a little more washed out. There's a thing called red desaturation, which is a way we check. And oftentimes if you show them red out of one eye and show them red at the other eye, the red will not look as brilliant red in the eye affected. At that point, I do some testing. And what's interesting about optic neuritis, oftentimes it's called retrobulbar. So it actually is inflammation behind the eye. Not always, but sometimes. So I've seen people where their nerve, their retina, their blood vessels, everything looks normal. Not to get too deep here, but there's a pupillary abnormality called an afferent pupillary defect, and there'll be red desaturation. And at that point, that's when I think of optic neuritis, even though the nerve looks healthy. Typically, in a young, otherwise healthy person, you have to consider the possibility of MS. So it's kind of an awkward conversation. You don't want to panic someone, 25-year-old young healthy person, say, "Oh, you have MS." On the other hand, you can't just say, "Well, you have inflammation in your nerve. Let's see how it goes." You're kind of obligated. So what I'll usually do is I get their medical doctor and/or neurologist involved, and I'll tell them, "Listen, and I've had this. I've had people that just had a post-viral inflammation of the nerve and they never had MS. I've had other people where they've had immune-related optic neuritis. But unfortunately, it is common to have MS when you see a young person with optic neuritis. Typically, the workup would be an MRI of the brain, looking for what we call white matter disease, but also the neck, because the neck sometimes shows things and the brain doesn't. And then also a spinal tap sometimes shows very specific finding. So that's how we do the workup. And I typically, at least in my practice, don't do that. Carl and I, when we were kids and we did a lot more neuro-ophthalmology, we would do that workup ourselves. The thing really is just, if you have decreased vision, you're of course going to see an eye doctor. The only thing I would add about Gilenya, it's a wonderful medication, some success, which is promising. I mean, anything for MS that can help people. So Gilenya, it has some promise. It's been around for a while. I know that it has some effectivity, although it was doctors and patients wouldn't be using it. There are the main risk, as Carl mentioned, is macular edema. So we check for it. We check to see if their macula is swollen. We do test macular OCT on them. There's also rare other side effects that are neurological from Gilenya that can affect the eyes, but they're really more of a neurological. So I think, yeah, Carl did a really good job. I hope I added some.
Well, thanks, John. Just to summarize the treatment landscape, there are injectables. They're called interferon beta and something called Copaxone. There's Avonex. Those are really the older medications. Think of them like a Pinto versus a Lexus or a fancier car nowadays. And we have monoclonals like acrelizumab and Tisabri, which is a really interesting drug, natalizumab. It does have some pretty devastating side effects called PML, progressive multifocal leukoencephalopathy, associated with that, and that can be devastating. So that's another conversation and another topic. But Tisabri has been a game changer for some. You give that through a port roughly once a month or every 6 weeks, depending on how you clinically respond. But these oral agents, these disease-modifying agents that we're really focusing on are something called Tecfidera, Gilenya, and Aubagio. And the Gilenya is the one we're talking about.
Gilenya can also cause PML. It's
Right.
rare.
It's super rare. But
Right.
I mean, Tisabri is known to do that.
Yes.
And the longer you take it, the more the risk goes up.
I see.
And there's something called the JC virus antibody titers, which you have to get to, which can be stored in the kidneys, and then they'll. But that's the neurologist or neuro-ophthalmologist will follow patients and monitor them for that. Again, that is unique baggage associated with those medications. But getting back to Gilenya as a disease-modifying therapy, they really do shape the relapse rate. However, as we mentioned, they have unique ocular baggage, which is this macular edema. And, if you do come across a macular edema, we treat it like we would macular edema for any other disease, which you can get during cataract surgery. We recommend non-steroidals, sometimes steroid drops can help. And we would also then change the disease-modifying therapy to potentially Tecfidera or Aubagio, but that conversation would need to be had. So really the screening protocol, macular OCT before you start the first dose, baseline dilated exam with your ophthalmologist, repeated every 3 or 4 months, then as needed, only if the visual symptoms arise. And your ophthalmologist like John or I, we would counsel you or our patients on prompt reporting of blurred vision or metamorphopsia, where lines get curved. If you look at a door jamb, it'll look curvy. It just won't be right. Gilenya is a really interesting drug, though, so I wouldn't shy away from it. It's known as an S1P receptor effector. And the reason you get macular edema is because those receptors live also in the retinal blood vessels, and that can modulate fluid leakage into the macula. This was done, by the way, in an interesting study called FAME, the Fingolimod-Associated Macular Edema study. And the other study that we referenced, the ONTT, which showed that IV steroids for optic neuritis, which is pain with eye movement as the vision decreases, usually in your 30s, females, IV was better than oral. Oral actually increased the relapse rate, but people got better and visual acuity got better in a great majority of people, around 90% to 20/40, even if you did nothing. So that's the
Yeah,
take-home
one thing I would
message.
add, yeah, I'm glad you mentioned that. It's kind of interesting. When I've seen optic neuritis from other conditions, it actually is more likely to leave the person with some type of permanent visual, like Leber's or things like that. Whereas most of the people, I mean, not all of them, but most of the people I have as patients with MS that developed optic neuritis, you can still see some mild sign of it, like a little optic atrophy or a little bit of a field cut, or maybe not quite 20/20 vision. But most of them, their vision does come back even without treatment.
There is always a bit of an impact, though. The
Yeah,
colors
absolutely.
will look a little washed
Yeah,
out. They'll have spotty visual fields. It's like maybe Swiss cheese-like. There is an impact of MS, and that's why we don't wish it on anyone. But
yeah.
really, the long-term consequences of optic neuritis need to be known and need to be monitored for. Because as I said, the ONTT trial from 88 to 91 did identify that if you have a bout of optic neuritis, you are quite likely, over 50%, to wind up with
That's,
MS after 15 to 20 years to be aware of. So
I have two close friends of mine that developed it over 20 years ago. Optic neuritis, and they never developed MS.
yeah, so not everyone does, but
Yeah,
again, you need to be aware of it.
yeah.
So the take-home message is demographics matter, younger women, higher latitudes. Your eyes are like an MS barometer, whether you have an
Also,
optic neuritis or an internuclear ophthalmoplegia. OCT, we use it as a biomarker now, which is, we didn't have this years ago when John and I were training back, and specifically shedding a light on Gilenya. Gilenya is effective, but it is not innocuous. Remember the fame risk at about 0.2 to 0.5%. This is not a lot, but when it happens, it's not fun. So you want a baseline dilated exam with OCT every 3 months for a couple of visits. It's non-negotiable. Early detection equals saved vision. And so you want to partner up with a neuro-ophthalmologist or a neurologist. Those are the take-home messages. We're really happy that you're here and that you stayed with us. We'll touch on Tisabri and these other medications because they're really interesting and the mechanisms are really fantastic
I,
physiologically.
I
So,
would add that you mentioned that when we were training, we didn't have OCT. We also didn't have television and phones
right, right. We
and
didn't.
cars. We
We
had
used, that's
horse and
right.
buggy.
John and I used to communicate with smoke signals.
Exactly.
Anyway, guys, great having you. Thanks a million for being here, and we will catch up on the next one.